Good evening to all doctors. I would like to thank you all for taking out your precious time from your busy schedule. This webinar is organized by Banai, Behavioural and the Neuroscience Academy of India. Banai is, hello?
Go ahead.
Okay. Banai is a not-for-profit organization formed in 2012. It has organized more than 200 programs nationally and internationally. Focus of Banai is to provide contemporary, cutting edge on behavioral neuroscience. Banai is formed and runs under guidance and chairmanship of Dr. E. Mohandas. Banai welcomes everyone and anyone who is interested to join. It gives me immense pleasure to introduce Dr. Ravi Soni as the moderator for today's webinar. Good evening, sir.
Good evening.
Thanks, Dr. Ravi Soni, for accepting to be the moderator for today's webinar. Dr. Ravi Soni is a consultant geriatric psychiatry at JIPS Psychiatry Clinic and De-Addiction Center, Ahmedabad. He is the first geriatric psychiatric and first DM in psychiatry in Gujarat. At present, he is the only qualified geriatric psychiatrist in Gujarat and Western India. He works exclusively for mental health issues and psychiatric illnesses in old age patients. More than 700 geriatric patients with mental health issues have benefited from his service in just a single year after joining JIPS Psychiatry Clinic. I would now request Dr. Ravi to take over and start session proceedings. Over to Dr. Ravi Soni.
Thank you. Thank you, Akanksha, for warm introductions.
Thank you,
and
sir.
now I'll introduce chairpersons. And today, for this session, we have two chairpersons whose names requires no introduction. But for the sake of formality, I'll try my best. Next slide, please. Uh, I'm feeling very privileged to introduce Dr. Sarvada Chandra Tiwari because he was and he is my mentor and guardian when I was in KGMC Lucknow for my TM. So he requires no introduction, but Dr. Sarvada Chandra Tiwari is a founder, professor, and head of Department of Geriatric Mental Health at King George's Medical University, Lucknow. He specializes in geriatric psychiatry. He is an eminent psychogeriatrician and also known as father of psychogeriatrics. Presently, he is the chairman of Mental Health Foundation, Lucknow, Uttar Pradesh, awarded many international and national awards. Many professional contributions are there, like he has developed Sarvada sign and socio-economical scale, which is widely used in country and abroad, many international and national research papers. And another thing that is not written here, he is the founding president of Indian Association of Geriatric Mental Health also. So very warm welcome to sir. Now, next slide, please. Now I'll introduce another eminent psychiatrist, Dr. IRS Reddy sir, who is consultant psychiatrist for last 38 years and director of Vijayawada Institute of Mental Health and Neurosciences, BIMHANS. We all have heard this name so many times. Served as national president in Indian Psychiatry Society 2007 and also president in SARC Psychiatry Federation 2007. Nominated as an expert psychiatrist in Andhra Pradesh State Mental Health Authority, published many articles in national, international journals, and also edited a book on career planning for younger psychiatrists. Has also served as a chairman of International Affairs Committee, Community Psychiatry Sections, and Awards Committee in Indian Psychiatry Society. Very warm welcome to the chair, sir. So
Thank you.
now I'll hand over mic to Dr. Reddy sir for introduction of our speakers for these sessions.
Okay, thank you, Dr. Ravi Soni. And first of all, my pranams to all the senior psychiatrists, Dr. Tiwari Saab, Dr. Wahia Saab, Dr. Ravi and Raghunath, and also my good friends Rajesh Nagpal and Venu Jawar for asking me to be one of the chairpersons for this today's evening session and a very important topic. So first, let me introduce our two honorable speakers. So I think first we'll introduce Dr. Ravi Raghunath. Yeah. So Dr. Raghunath is a senior consultant neurologist at Sun Medical and Research Center, Thrissur, Kerala. That is the home place of our founder, chairman of this Banai, Dr. Mohandas. And Dr. Raghunath is a well-known neurologist and also not only a clinician but a good speaker. And his areas of expert, of course, like epilepsy, stroke, headache, dementia, migraine, paralysis, vertigo, whatnot. We already heard him a number of times. His excellent lectures in many fora. So welcome to Dr. Raghunath for today's session. So he's going to speak probably on some of the neurological aspects of forgetfulness. Then coming to Dr. Wahia Sab. So I think about Dr. Vihang Wahia Sab, there is nothing to say for all the psychiatrists in the country and not only in India and also abroad. His name is very familiar. It is a household name, Wahia's name. And he is a consultant psychiatrist at Breach Candy and Leelavati Hospitals, Mumbai. And he is a member of the DSM 5 task force. He has contributed significantly to that. And also is a member of the National Advisory Board of the Indian Association of Private Psychiatry. And also he was the former chairman of CAP committee of the IPS and also IAPP in both the leading professional organizations of our country. And he was the past secretary, honorary general secretary of the IPS, and also the international distinguished fellow of the American Psychiatric Association. And not only that, he was a past member of the membership committee of AP also. And he has several publications in indexed journals and also chapters in textbooks and monograms. So with this brief introduction, let me also, anyway, our Guruji, Dr. Tiwari Swami is going to briefly introduce about the topic also. I think I just want to say one or two, I will just take a minute or so about this topic. So when they have said, Venu told me about forgetfulness, I thought maybe something like dementia, some very common topic, why there is something special about it. But when I carefully saw it, it is just not an dementia, but it's just forgetfulness. They have very intelligently coined that term forgetfulness. Then I was a little thinking about it, what exactly. So in my opinion, probably forgetfulness is more normal phenomena of our day-to-day activities like forgetting specs or purse, whereas amnesia probably more pathological. Probably here we have got one neurologist and one senior psychiatrist. Both probably will be dealing on the one on the neurological or the brain, and probably Wahia Saab may be dealing about the aspects. Other thing is the motivated forgetting. So that is more of a like repression and suppression. All of us know what is repression, the subconscious burying of our memories, and which based on the Freud psychoanalytical model, and which has got a lot of impact on our day-to-day behavior, emotions and dreams, decision making, whatnot. Of course, suppression is the conscious phenomena of burying our memories. And whereas the dissociative amnesia is another thing where it occurs after very traumatic episodes of traumatic emotional trauma, and where forgetting is a bliss. It is in such cases, it is forgetting is really a bliss. It is not pathological or it is not harmful. Probably it gives that type of forgetting is sometimes bliss. And also, finally, it is not the time. Many times we say that time heals many of our wounds, emotional wounds. But I think more than the time, it is the forgetfulness that heals our emotional wounds. And before I close, so when Venu was asking me, sir, why you were speaking mostly on cinemas and other thing. So probably I said it is very difficult to cinema and forgetfulness, but I am just reminded of one song of 1960s of Sanjog of Bollywood, where Mukesh sang this song, and A Disappointed Lover, and Rajendra Kishan as lyric and Madan Mohan's music, where he says, Bhuli hui yaadon, mujhe itna na satao, भूली हुई यादों मुझे इतना ना सताओ, अब चैन से रहने दो मेरे पास ना आओ. So probably I think all of our colleagues in this webinar, they understand there are so many such lyrics in all the languages, even in Telugu and all the languages, where disappointed lovers are the people who are with some tragic experiences. They sing this song, and this is a song which probably similar to the forgetfulness is a bliss. It is not need not be pathological always. It is not harmful. Probably without forgetfulness, our lives would have been much more miserable. So ultimately, it is a bliss. It is a blessing in disguise. Probably for many people, forgetfulness is a God's gift also. With these few words, Now I'll request our Tiwari Saab to say a few words about this topic, and then we'll go to the speakers. Thank you for giving me this opportunity.
Thank you. Thank you, Dr. Reddy Saab and Dr. Soni, Ravi Soni, for saying so good words about me. And लखनऊ से सभी participants को शाम का सलाम. The important aspect of this webinar today, which is on a simple topic, forgetfulness, is very much. I am sure all of you agree that many times even normal forgetfulness, which is occurring in relation to age, is taken as totally abnormal, and people are so sensitive and worried about it that they keep on talking about their forgetfulness. Though on memory examination, there is no objective memory impairment. They present with symptoms like frequent asking questions about some issue, and also they remain bewildered on certain situations. A memory was there just right now, and then they forget for some time and again regain it. It doesn't cause difficulty in their working except subjectively complaining about memory problem. And they consult doctors about forgetfulness, which turns out to be that the complaints are limited only to subjective complaint, and on objective assessment of memory, there is no memory impairment. On the other hand, there may be changes in mood and personality. These people might have difficulty in speaking, in finding some words, but then afterwards they may recall it. These things make them very sensitive that they are forgetting things, but this forgetfulness is at subjective level, not at objective level. On the other hand, the memory impairment in the immediate condition, which is little more pronounced, is age-related memory impairment. And in that, things may worsen, and these are the people, they often lose things. They forget to go to events or appointments, having more trouble coming up with words than other people of the same age group. That means the memory impairment is gone little beyond the normal forgetfulness, and the person he complains subjectively about memory problem, and on objective assessment as well, there's a memory impairment. The condition is termed as mild cognitive impairment when objectively the memory impairment is detected. Many elderly people suffer from this subjective complaint, and some of them also with early signs of mild cognitive impairment. They always attract attention of psychogeriatricians, other psychiatrists, and physicians, and often visit hospitals with complaints of memory impairment. Simple consolation, talking and showing that there is no objective memory impairment is enough to rule out the possibility of a normal mild cognitive impairment. and tell them this is normal. In that situation, agree to such kind of counseling and such kind of objective assessment of the memory problem. The topic is very relevant, and the speakers are, I'm sure, will highlight the problems are forgetfulness, both normal, subjective, and subjective as well as objective memory problems. By not taking much of time, I request the first speaker to speak on the topic of the day. Thank you.
Can I share the screen? Can I share the screen?
Please do that.
Yes, sir.
Yeah. I'm audible, right?
Yes, you are.
Okay, thank you.
Audible and visible. No, you're not visible suddenly. Please switch on your video as well. Dr. Raghunath, you are not visible.
Yeah. Just a second. Okay. Is that okay now?
Yes. Except
Is that
that
okay?
we are seeing you. And we are seeing Dr. Tiwari, not you.
Okay, my video is on anyway. So as soon as I speak, I probably become all right.
Now you got you.
Okay, let me at the outset thank the organizers for giving me this opportunity to speak in front of this august audience. And I especially thank the Dr. Reddy for the kind words of introduction. And hope I can give an overview of the topic, forgetfulness. So forgetfulness is something when the patients come to you and say that your memory is not as good as it was before, that you keep forgetting things. My mind is not okay. There's something wrong. I'm not as fast as I was before. So these complaints are, again, they come in the background of the fear of having dementia. So episodic memory, as you all know, episodic memory decline is a hallmark of Alzheimer's disease as well as many of the dementias. And self-reported subjective memory complaints like that of forgetfulness actually may not reflect impairment and does not equate with a diagnosis of dementia or even a forerunner of dementia. So proxy reported memory impairments may have more value, though it is not conclusive. So I'll just highlight a few dementia facts just to give you the importance that forgetfulness might be the tip of the iceberg, and maybe it is hiding a person who might have some risk for dementia. So currently over 50 million people worldwide living with dementia. It's set to rise to 152 million by 2050, with the greatest increases in low and middle income countries. So India is going to bear the brunt of the problem. A new case of dementia arises somewhere in the world every 3 seconds. Up to 3/4 of those with dementia worldwide have not received a diagnosis. And almost 80% of the general public are concerned about developing dementia at some point, and 1 in 4 people think that there is nothing we can do to prevent dementia. And almost 62% of healthcare practitioners worldwide incorrectly think that dementia is part of normal aging. And 35% of carers across the world said that they've hidden the diagnosis of dementia of a family member. And over 50% of carers globally say that their health is suffered as a result of their caring responsibilities, even while expressing positive sentiments about their role. So forgetfulness can be taken as a part of normal aging, and sometimes it might be an indicator of a dementia. So it's very important that you assess forgetfulness and try to get to the bottom of why this patient is having the complaint of forgetfulness. Now, if you look at subjective cognitive complaints, of which forgetfulness is one, who is at risk? There have been several studies, and this slide is taken from a meta-analysis which was done in 2015.
अगर कुछ कर पाएंगे तो वही कर पाएंगे.
So it shows that there is a prevalence of 50 to 60% in elderly and it increases with age. Metacognition or awareness of one's own impairment of memory is variable. Some people somehow have probably that metacognitive sites of the brain also might be involved. So some people have an awareness that they have got impairment while other people are not aware. And great majority of them are worried well. And these are the people who are actually well. They don't have dementia, but they have this worry that they're forgetting things and they might be on the cusp of a diagnosis of dementia. And subjective memory complaint is a risk factor for dementia in the short run. So if you find that a person has got a subjective memory impairment, he has got a high risk of getting dementia in 2 to 3 years. But if they don't get the dementia in 2 to 3 years, they have a low risk of, or the risk is much lower of getting it in the long run. And the presence of subjective memory complaints was associated with 1.5 to 3-fold increase at risk of dementia or mild cognitive impairment. And subjective memory complaints over the course of time is quite unstable and unpredictable. And many of them, vast majority of them actually revert to normal. Now, things that keep them at risk of getting converted to MCI or dementia is an impairment of instrumental activities of daily living, corroboration of the complaint by a family member, and higher education. So people with higher education who complaints of forgetfulness are found to be at higher risk of getting a further diagnosis of MCI or dementia. In a very recent Danish study, which was done in midlife among persons in occupations, the complaint of forgetfulness was associated with incipient dementia at a later age. So this was published in 2019. Now, before we go into forgetfulness, we just have to look at the trajectories of normal aging. So this, again, a review article by Salthouse in 2019 has this beautiful graphs of the crystallized intelligence and the fluid intelligence. The fluid intelligence like memory, reasoning, and the speed of cognition. So all these decline with age. So you can see the memory has got a declining, and reasoning also declines, and the speed of cognition also declines. But the vocabulary or the crystallized intelligence, or the semantic memory actually remains stable and declines very little over time. So this is this is what you should be aware of when you actually test these patients. So once you have, like Professor Tiwari mentioned, once you have this patient who has got a complaint of forgetfulness, which is self or informant-reported cognitive decline, then you have to see whether they go into this group of mild cognitive impairment, because many of them might go into this group of mild cognitive impairment. Now, how do you define mild cognitive impairment? These patients should have preserved daily functioning, impairment in one or more cognitive domains, and does not meet the criteria for dementia. So they have got impairment in one or more cognitive domains, but does not meet the criteria for dementia, and they've got preserved activities of daily living or instrumental activities of daily living. So these people go into mild cognitive impairment. And once you have this diagnosis or this idea that might be a mild cognitive impairment, so you have this report of cognitive impairment or forgetfulness by the patient. Now you have to see whether there is any, you have to see that it is not normal. Then you have to see whether it is not dementia, and there is a definite decline in cognition or memory with a preserved functional abilities. Then you go into this memory impairment group, and now we have to see whether memory alone is impaired or there are other cognitive domains are involved. And if you say that there is no memory impairment, you have to see that it's a single non-memory domain or a multiple non-memory domain. So it goes into either amnestic MCI or non-amnestic MCI. So this is how it's classified. So amnestic type of cognitive impairment is when you have a memory complaint, preferably corroborated by an informant, preferably by a family member, and memory impairment relative to age-matched or education-matched healthy people, typical general cognitive function, largely intact activities of daily living, and not clinically demented. And this is how you should go about classifying it. Now we have to see whether it's an amnestic mild cognitive impairment or a non-amnestic mild cognitive impairment. It's a single domain. It might be Alzheimer's disease. It's a multiple domain also. It can be Alzheimer's disease with a little more progression. Then you have to see whether if the patient has got stuttering progression, got a history of strokes. It might be a vascular dementia. You have to got high index of suspicion for depression. So you have to have a psychiatric or a psychological evaluation for depression. So depression can present with either a single domain impairment or a multiple domain impairment. And you have to look for a lot of medical disorders. Similarly, in the non-amnestic mild cognitive impairment also, you have to see whether it's a frontotemporal dementia, it can be a dementia with Lewy body disease, or it can be one of the variants of Alzheimer's disease, like primary progressive aphasia or logopenic Alzheimer's disease, or the posterior variant of Alzheimer's disease. All these can present with a non-amnestic mild cognitive impairment, later on progress on to become an Alzheimer's disease. Now, the patient has got sleep disorders, REM, sleep behavior disorder. All these you have to look at dementia with Lewy body. And again, stuttering or a history of stroke, you have to look for vascular dementia. And again, most of these cases, you have also to look for medical disorders. So once you make a diagnosis of mild cognitive impairment, you have to make sure that it's not mild dementia, that where the differentiation is made by the ability to function at work, or an objective or low performance in more than one cognitive domain, which is greater than expected for patient's age or educational background. So to look for these things and make sure that it's just mild cognitive impairment and not mild dementia. Now, the cognitive trajectory of a patient with dementia versus no dementia is, you can find that both the person who is destined to have dementia and the person who's destined to have normal or become non-demented, they actually go parallel for a long time. Then there's a mild, gentle slope in which they have this mild cognitive impairment, and then they go down and become dementia. Now, this time frame is very important to recognize, because you might be able to, at that point of time, have some intervention to slow down the progress of the disease, or probably you can put them into trials and see that if there's something is reversible, can be actually found out and done. So one good thing to do is probably to look at this functional activities questionnaire. So have checklists on what all to do. Probably functional activity questionnaire is one of them. So in the past 4 weeks, does the patient have any difficulty or need help with writing checks, paying bills, balancing checkbook, assembling tax records, business affairs or other papers, shopping alone, playing a game of skill, working on a hobby, heating water, making a cup of coffee, turning off stoves with females, preparing a meal, keeping track of current events, following a television show, book, or magazine, being able to discuss them with acquaintances, remembering appointments or remembering to take medications, keeping track of recent conversations, recent events and the date, driving, traveling out of the neighborhood and coming back safely, arranging to take a public transport. So all these things are very important in finding out whether patients got a impaired activity of daily living. And one useful sign is when they come to the clinic. Attendant alone sign is one when the patient comes alone and says that he has got a complaint of forgetfulness. So it might be that he is a worried well. More indication is that if he has come alone and has been able to do all the registration and all that, even when people have been told to bring an attendant, some people come alone. And when they give this complaint of forgetfulness, it might indicate that probably he is one of the worried well. Head turning sign is when the patient actually, when you ask him a question, he turns towards his caregiver for that person to give the answer. So that is the head turning sign. Applause sign is when you ask a patient to give 3 quick claps. As the patient is able to repeat it, it might indicate that he is just worried well and might not be affected, or might not be having a mild cognitive impairment, or might not be having a serious complaint. But if he's not able to do the 3 quick claps, it might indicate that he must be having a serious complaint. And one thing that you have to do in the clinic is to make sure that he does not have one of these reversible causes of cognitive impairment. This is not a complete list, but this is a very short list, but it contains, I put this up because it contains all the important things that you have to surely make sure that it is not there. So you have to look for the drugs, polypharmacy, hypotension, orthostatic hypotension, depression, hypothyroidism, vitamin B12 deficiency, hyperglycemia, dehydration, sensory loss like visual hearing impairment, obstructive sleep apnea, normal pressure hydrocephalus, atrial fibrillation, and infections, especially CNS infections, and even sometimes non-CNS systemic infections. You have to make sure that all these causes of reversible cognitive impairment is not there. Once you have done all that, and you think that the complaint of forgetfulness is very serious, you have to go in for a ideal cognitive screening instrument. Now, the ideal cognitive screening instrument should take only less than 15 minutes to administer by clinician at any level of training. Ideally, should sample all major cognitive domains, including memory, attention, concentration, executive function, visuospatial skills, language, and orientation. Should be reliable with adequate test and retest and iterative validity. Should be able to detect commonly encountered cognitive disorders. Should be easy to administer. That is not much equipment required beyond pencil and paper or laptop computer. Should be easy to interpret. Clear test cutoffs, perhaps operationalized. Example, a particular score of the test should lead to particular actions such as patient reassurance, continued monitoring of cognitive function over specified periods of time, or immediate initiation of several investigations or treatment. Now, I'm sure that you're familiar with many of the cognitive screening instruments. Mini-mental status examination is the one which is most commonly used, though it is being replaced by several other ones. Clock drawing test and reverse clock drawing test is another examination which you use. Codex examination is there. Adambrooks cognitive examination has got a very high sensitivity and at least more specificity than most other examinations. Now we have the revised version of Adambrooks cognitive examination, which is in use. And the Montreal cognitive assessment is rapidly gaining in popularity. Test your memory is another one which is again been recently assessed. Frontal assessment battery is another one. There are several other tests also, but you can be sure that none of these screening instruments are the best, or you probably have to choose from these to actually find out one that you are comfortable using, one that is more familiar to you, and one you can validate. So you have to choose one of these. Now, the difficulties with the MCI diagnosis is a lack of consensus on uniform criteria, highly variable preference rates of 1 to 30%, annual rates of conversion from MCI, though people say it's 10 to 15%, but in studies it varies from 1 to 72%. Samples drawn from memory clinics have higher rates of conversion. Rates of reverting from MCI to cognitive normal is also varying, ranging from 10 to 40%. And instability of the diagnosis of MCI may relate to the subtype, and you find that single domain presentations are more unstable, so that they can either revert to a cognitively normal or to a dementia diagnosis very quickly. So this in the Alzheimer's disease is seen as a cognitive spectrum, where you have a preclinical Alzheimer's diagnosis, preclinical Alzheimer's disease, then to MCI due to Alzheimer's disease, mild dementia, moderate dementia, and severe dementia. And the International Working Group probably has a different nomenclature, where you have a symptomatic at-risk state for Alzheimer's disease, prodromal Alzheimer's disease or pre-dementia stage, mild Alzheimer's disease, moderate Alzheimer's disease, severe Alzheimer's disease. And probably most of our patients who come with a complaint of forgetfulness, we have to see whether they belong to the first two groups. So the talk mainly focus on these two groups. Now, we all know that there have been a lot of elegant studies which have shown that the disease process of Alzheimer's disease actually starts much before they have subjective complaints and much before they receive a definitive diagnosis of dementia. So this is a study in which cognitively normal people, you find that they have elevated amyloid long before they have this diagnosis of dementia. The it starts off much before you have this diagnosis of dementia. And this is another one which is a very common, I'm sure that you must have seen this slide several times in several talks. This is the one which shows the detection threshold of various biomarkers for MCI or Alzheimer's disease. Where you see CSF beta 42 is the one which appears first. Then you have the amyloid PET. Then you have the CSF tau. Then you have the MRI and FDG PET. Then you have the cognitive impairment. So cognitive impairment actually most of these biomarkers actually predates the cognitive impairment, so that you might have a condition in which the patient is cognitively normal with the presence of biomarkers. So probably when your patient coming with forgetfulness, you have to also try to see whether he actually falls into this biological definition of Alzheimer's disease, taking into account the biomarkers. So recently you have this new definition of Alzheimer's disease, in which Alzheimer's disease is now seen as has got a biological definition, in which you have the clinical state as well as the pathophysiological marker, which can be the CSF as an amyloid PET or volumetric MRI and other imaging tools, which can actually see whether the patient has got more risk of developing Alzheimer's disease. So your asymptomatic patient or the pre-symptomatic patient, or the ones who has got mild complaints, you can actually, if you find they are serious enough, you can actually go for the testing of these pathophysiological markers and see if they come where they lie in this spectrum of Alzheimer's disease. So you have biomarkers which can define the disease, which are amyloid as well as tau. You have biomarkers to stage disease, which are MRI atrophy, the FTG PET, as well as CSF total tau, which these actually show the neurodegeneration, while these actually show the specific degeneration, which is specific to Alzheimer's disease, that is amyloid and tau. And the clinical examination and the clinical staging will actually stage the disease. So the 18 biomarker grouping is the one which has been recently advocated by Jack et al. And then by the paper which is published in 2018. So you have A is for aggregated A beta amyloid peptides or associated pathological state. So they actually mark the Alzheimer pathological state. And these are CSF A beta 42 or the CSF A beta to A beta 40 ratio, and amyloid PET. So these actually indicate the deposition of amyloid in the brain. And T actually stands for aggregated tau, which can be seen by CSF phosphorylated tau as well as tau PET. And N is for neurodegeneration or neuronal injury, which is shown by the anatomical MRI, which shows the degeneration or the decrease in the brain volume. FDG PET, that is FDG glucose PET, and then the CSF total tau, which is also a marker for neurodegeneration or the neuronal injury. And the definition along the Alzheimer continuum is by amyloid biomarkers to determine whether the individual is potentially in the Alzheimer's continuum. So if you have a just the biomarker without the tau, you probably have an Alzheimer's pathological state, but not Alzheimer's disease. So to have the Alzheimer's disease, you have to have the tau also, which indicates that there is some damage to the brain. So this actually determines if someone is who's in the Alzheimer's continuum as an Alzheimer's disease. So just the amyloid marker will be in the Alzheimer's continuum, but to make sure that he has got Alzheimer's disease, you have to also indicate that there is damage because of the deposition of the amyloid. And neurodegenerative neuronal injury biomarkers provide powerful prediction of future cognitive decline, and cognitive symptoms determine the syndromal categorical cognitive staging regardless of the etiology. And A and T are specific neuropathological changes for Alzheimer's disease, while N and C are not specific for Alzheimer's disease, and so can actually also show, is indicative of any dementia which also produces neurodegenerative changes as well as neuronal injury. So this is the trajectory of the CSF biomarkers in non-demented. So you can see that in these patients, there is a lot of changes in the CSF biomarker trajectories before actually the patient gets a diagnosis of dementia. So many of these patients can actually be found out when they come to you with the non-specific complaints of forgetfulness. If they are evaluated, probably you might, some of them might fall into one of these pathophysiological spectrum. And you find that once you have these biomarkers, many of these patients have a different trajectory. Their course is much different once you know where you place them. So for example, A plus will have a different course, A plus T minus has a different course, and A plus T plus has got a different course. So if you know them, you find that many of these patients will have a different trajectories. And if you imagine that At the age of 50, if you find that 100% of the patients are cognitively normal and they've got A minus, N minus, that is, they have no pathological change of Alzheimer's disease and they have no change of neurodegeneration. This is how the trajectory goes. So as they reach about 70, probably 1/3 of them will start having these markers. And slowly you find that more and more of these people will have these markers and these graphs will start going up. So what is the prognosis of patients once you put them into a classification of mild cognitive impairment? So they've got a higher risk of progressing to dementia than age-matched controls. And in individuals older than the age of 65 years, followed for 2 years, the cumulative incidence of development of dementia is 14.9%. And those with MCI diagnosis at 2 to 5 years, this is what I said, that they've got a higher risk of developing dementia in the short term. But if you follow them up for a longer term, you find that the RR for dementia is actually less, and the RR for diagnosis of presumed Alzheimer's disease is also less than what it is in the short term. And persons diagnosed with mild cognitive impairment may remain stable, return to become neurologically intact, or progress to dementia. So all of them, they have got a varied trajectory. So they can either remain stable, return to neurologically intact, or progress to dementia. But always remember that in a person with dementia, Alzheimer's pathology is not the single. It is the largest group, but you can also have other pathologies, especially TDP43, like hippocampal sclerosis. This is a new one which is found commonly, which can present exactly like Alzheimer's disease. Alpha-synuclein is another one. The vascular disease is a different one, and many other causes can also be there. So it's very important to realize that it is just not A, beta, and tau, which are the markers of Alzheimer's disease. It can also be various different pathologies out there. And this is my last slide. And in conclusion, I would like to state that robust epidemiological evidence exists that a subgroup of patients with subjective memory complaints like forgetfulness progress to dementia. So we have to take them in all seriousness. At the same time, the worried complainers, persons with impaired IADL, and those with the higher education seem to be more at risk. So these are the groups of patients you have to take with more seriousness. But a vast majority of these patients do not progress to dementia, and care should be taken to avoid unnecessary examinations and investigations which might lead to these patients to have more stress. And the addition of biomarkers in selected patients may add value to the evaluation of these patients according to the new biological definition of Alzheimer's disease. Thank you. Thank you for the patient listening.
Thank you, Dr. Raghunath. It was a very elaborate kind of talk on forgetfulness as part of dementing process. Before losing any time, I request Professor Vihang Vahia to tell us about this important issue of forgetfulness, and we can take up the questions after both speakers have spoken. Over to Professor Vihang Vahia.
Thank you, Tiwari Saab and Dr. Inla Saab. Probably the only reason why I'm here today is my age. At my age, this topic is of greatest relevance, and that's put me here. Otherwise, I do not claim to have any special knowledge on memory difficulty and cognitive decline amongst our patients. Dr. Raghunath, it's such a pleasure to hear you. I think there is something in the water supply of Thrissur which seems to breed academics in every medical professional. And I have a special affection for Thrissur. My best ever friend in my life, Dr. S.P. Ramesh, was a psychiatrist in Thrissur. And the last time that I got to visit Trishur was for his funeral. And that's also left behind memories which are not going to go away very fast. So, memory difficulty and the relevance, academic and clinical relevance, has been extensively covered both by the chairpersons and, of course, by Dr. Raghunath. Let me share with you how I go about with my patients of memory difficulty. About 40 years ago, somebody told me that there are people who know that they know. They are the bright people, and it's best to learn everything that they say if you are willing to tolerate some arrogance. There are those that know that they don't know. They are the learned, educated people who are trying to acquire more knowledge. Then there are those that know not that they know, are probably the anxious and depressed who undervalue themselves. And then there are those that know not that they know not, are terrible. Stay away from them. I apply this to my clinical practice. When a patient comes and tells me, patient above the age of 55 or 60, more like after 65, comes and says, "Doctor, I don't remember," it brings a smile on my face. And I tell them that the fact that you have mentioned that you don't remember has taken the load off my head of making a diagnosis that I might not be very happy to reveal to you. When a person presents with subjective sense of memory difficulty, without objective evidence, like Dr. Tiwari said, of validating presence of cognitive deficit, are the patients who I like to deal with, partly because of my age and partly because you're not going to be prescribing or proposing a diagnosis that's not a very pleasant diagnosis to reveal. My first step is to put the patient at ease. And I would say that in the narration that you have made so far, the fact that you think that you don't remember or that you are convinced that you don't remember is music to my ears. Because people who have real or true cognitive memory difficulties don't remember that they don't remember. So the fact that you remember that you don't remember is music to my ears. And the second metaphor I tell them is again something that I learned from my teacher, Dr. Jeste. He said, when a person in the age range of 20 to 30 goes to the airport, he would put two bags on the trolley, hold one bag or a stroller in one hand and a child in the other, and walk to the check-in counter. Whereas at my age, even with one bag on the trolley, I need to use two hands. That doesn't mean I have turned weak. It's a part of the age. Things will happen slowly. And if you don't make yourself anxious, that path for your memory stores to get acclimated or to get paired with the words so that you can speak becomes easy. So the focus of treatment is to remove the anxiety and depression. That's the first step that I begin with a patient who complains of memory difficulty around the age of 60, 65. And tell the patient that if you had not mentioned that you have some memory difficulty, it would have caused concern. But the fact that you have mentioned has taken the burden away. Of course, this is not to undermine the need for looking at the biomarkers and the investigations that Dr. Raghunath so nicely mentioned. And I would ask the patient to go through that investigations only when I feel that the patient is reassured that the investigations are being done by way of completion of the medical records and medical drill or the algorithm that goes that the doctor has to follow, and not because the patient is potentially suffering from a disease that the doctor doesn't want to reveal at the first consultation. When I come to the younger, somewhat younger, people in their age range of 30 to 40, I'm reminded of the couplet that Dr. Inla recited. भूली हुई यादों मुझे इतना ना सताओ. One of the lines that comes is, दीवाना हूं मैं और ना दीवाना बनाओ. These are the people who are struggling with unpleasant memories that they don't want to recall. And I went through a presentation. I don't have his permission, so I won't mention his name. But he said, there are two kinds of memories in our life or in our lives, the pleasant memories and the unpleasant memories. And as the current knowledge of science tells us, the unpleasant memories seem to be glutamate mediated. And glutamate mediated memories get engraved on the brain. Whereas the happy memories are GABA mediated, they get erased. The clinical application is that when I have a person of depression or anxiety who's feeling guilty, he would recall all the unhappy events in the person's past and blame the person, or he or she, and blame self for having taken a series of wrong decisions all the life that has now put the person in a terrible frame of mind and probably even the situation. A case like this needs to be investigated from the point of view of severe emotional stress, which could be reality based, or depression or anxiety. The diagnosis of this is beyond the scope of today's talk. I would reassure the patient here again that wisdom lies in using your faculty rather than blaming yourself for what you perceive as your defects, unless somebody else tells you that these are your defects. People my age or even 20 years younger than me would have come across couples who are about to break themselves up. The marriage is on the rock. And they would keep complaining about how bad the other person is. So I would hear them out and give them a piece of paper to make a list of all the bad things about their spouse. Then I would tell them that if the marriage has lasted 10 years or 5 years or 15 years or 20 years, whatever that there is, there must have been some good, happy moments in your family life. I give them another sheet to make a list of happy moments in life. Sometimes the couples want their time. So I would give them the two sheets and tell them to come and see me the next week. If the negatives in their life outscore the positives in their past life so far, past life together so far, not past life isn't past life regression. And a large number of couples don't come back. They just phone me up and say, doctor, you just made us look at life differently and we don't need to come to you. I feel sorry, I would lose a case, but happy for the patient that they've made up. The problem then comes up of anxiety, and especially anxiety related memory difficulty in still younger age groups. Anxiety before examinations, anxiety because of personal conflicts, all manifesting as memory difficulties. These are the patients who would require pro-cognitive antidepressant or anti-anxiety drugs. So I would consider, there was a question, do SSRIs cause memory difficulty? As far as I know, SSRIs can be considered as pro-cognitive. It's the sedation that would probably make memory somewhat delayed recall or slow in recall. One drug that I would hate to prescribe, and I would take off the current prescription if the person has that, is benzodiazepines. Because benzodiazepines do cause autobiographical memory lapses. So when I'm seeing a patient who complains, who subjectively complains of memory difficulty in the age range of adolescence, I don't deal with children, but late adolescents to about 50, I would want to look at the iatrogenic causes of memory difficulty. They have been elucidated so well by the previous speakers, I'm not going to repeat them. When I come across a person who complains of memory difficulty beyond the age of 60, 65, up to 80, 85, I would want to start with reassuring the person, to take away whatever the anxiety and let the patient not ridicule himself or herself, and then investigate thoroughly along the line that Dr. Raghunath has so wonderfully mentioned. And then if I have to reveal a diagnosis, I would be a little careful. Not straight away say, sorry, old chap, you are now finished for your life because you have a disorder which is going to progressively make you worse. I would still want to reassure them and get them to make as many efforts as they can to somehow retain their cognitive faculties as best as they can. So I do advise them going for walks, doing various kinds of pro-cognitive activities. And I do believe that this mild, subjectively perceived cognitive deficit somehow does seem to respond to a drug like donepezil. I could go on and on and on with this. It's important to rule out objective memory lapses from subjective memory lapses. Largest chunk of our patients have subjective memory lapses. Few of them have objective memory lapses. And the person in the older age groups who have subjective memory lapses should be monitored to look for any forthcoming objective evidence of cognitive deficits, which are best investigated when the patient is not anxious and then treated along the lines that our neurophysician friends tell us, and various other non-drug therapies. It just so happens that I have a conflict of family interest. My own son, Ipsit, is the director of geriatric psychiatry at the McLean Hospital of Harvard. And his forte at this point in time is the use of technology in the care of the elderly. They have stopped using the word elderly or geriatric. The term used is older adults. I love that term because it is so respectful of our patients and for me, people of my age. We are older adults. We are not geriatric or the elderly. Most patients till the age of about 80, 85, don't talk of people like Mr. Tata who are an exception, but average Indian citizen till the age of 80, 85 is much more active today than what they used to be when we were young. So these are the older adults who need to be treated with dignity and every activity that we can encourage to improve their self-confidence. Don't push in medication unless you know what to expect. Don't do it on a guesswork. A pill for every ill is a terrible idea. And for God's sake, keep away from benzodiazepines. I was given to believe that this is a webinar which goes on from 8 to 9:30. So we have exactly 30 minutes for questions. I'll take the easier ones. The more difficult ones, Dr. Raghunath will take. So let's have questions. Of course, the chairpersons will take all the other questions. I'll just sit back and smile. Thank you very much. Dr. Inla, sir.
Yes, sir. Thank you, sir. So nice. As usual, you have got a very unique style with fun and all these things. So we enjoyed your talk. We forgot, actually, ultimately. Anyway, we enjoyed your talk. As you said, I think now we'll go for the question and answer session. And the questions will be for both the speakers, especially. And of course,
and the chairpersons. The difficult one goes to Dr. Raghunath. The tricky ones go to you and the
okay, we'll obey your orders. Okay, now over to the so who will coordinate, the moderator, the Akanksha? Who will do this from the?
Yes, sir. I'll do. I do the questions.
Please, sir. Okay.
So there are so many questions, but the first that interests me about forgetfulness is that memory deficit and nutritional deficiency. So I feel that Dr. Raghunath will share some knowledge on this memory deficits and nutritional deficiencies.
No, you will tell the name of the person who is asking the question also.
Yes. Dr. B. Srinivasan has asked this question.
Okay.
Okay, the most common again is the vitamin B12 deficiency, which is the most common one in which you have this cognitive deficiency. So that is one that you have to make sure that, especially in vegetarians, you have to look for vitamin B12 deficiency and say that it is. The other vitamins, as well as minerals. All these should be also looked into. Then you have to look at drugs which might impair the absorption or the function of the vitamins, like biguanide is one which can impair with the B12 activity. So similarly, so you have to look at this in a broader perspective. You see all the medications that he's taking, the food that he's taking, and see that if he's likely to be deficient in one of these vitamins or minerals. And this is a very important cause, because many a time you find that B12 deficiency actually is a great mimicker. It can come in various forms. So you might miss the diagnosis, and it's easily reversible condition. And the treatment also, you have to see that some of them actually respond only to injectable vitamin replacement. So you have to be sure that what kind of vitamin deficiency you're dealing with, and make sure that you give the correct form of replacement. So this is how I would tackle a nutrition disorder.
Thank you, sir. There is a question from Arvind Baliramsa Sirvate, and a very interesting one. I feel that Dr. Vaya sir will throw some light over this. Does everyone complaining about forgetfulness needs to be treated or not? So, Vaya sir is muted, or?
Am I audible now?
Yes, sir. Yes, sir.
Anybody complaining of forgetfulness
Needs to be
should
treated or not?
Huh?
Okay. Yes, sir. Yes, sir. Go on.
Anybody complaining a memory problem should be evaluated to settle the diagnosis, whether this is part of normal forgetfulness, or this is age-related forgetfulness, or this is forgetfulness of MCI, or this kind of forgetfulness is progressing towards dementia. If it is in the age, if it is a subjective memory impairment without any objective sign of memory loss, memory impairment, he needs a consolation. He needs to be evaluated in a setting where there is no anxiety, the patient is comfortable, and one needs to tell that, see, all your memory functions are within normal limits, you are unnecessarily worrying. Many times, this kind of normal forgetfulness could be part of depression, or even some diabetics, or even in some kind of addiction. But that should all be taken care of. But it is not to be diagnosed till there is objective memory impairment. Similarly, for age-related memory impairment, the subject needs to be counseled, and though it is not scientifically advised, yet people are using anti-dementia drugs in mild cases, which I believe is not correct, and they should depend upon some antioxidants, some kind of memory exercises, non-pharmacological management, and they should be told about this kind of age-related memory impairment. For MCI also, one has to be very watchful, periodic follow-up of the patient, and the moment roughly about 13% they switch over to dementia, and there they certainly need treatment. But evaluation in a comfortable situation is the prime line of approach for managing the problems of forgetfulness. Thank you.
Thank you, Diwali sir. There is another question from
May I
Dr.
just add, Dr. Saab, my internet played up, so I was kind of offline for a while. But I
Okay,
heard
sir.
Dr. Raghunath mention the need for vitamin B12 and B6. Clinically, one of the commoner findings that we have nowadays, at least in Mumbai, are electrolyte imbalance. And that's what needs to be really taken care of. And another iatrogenic factor that I see is people taking these protein shakes, and these protein shakes causing renal impairment is another factor that we need to look at when people complain of vague symptoms, including vague memory lapses in the age of 65 and above, 60 and above. Thank you, doctor.
Thank you, sir. There is a question from Dr. Satish Nagargoje. This is more related to dementia. He's asking how to distinguish between late onset psychosis with dementia and Lewy body dementia clinically, because one responds to APD and other worsens with APD. So I feel that Dr. Raghunath sir can throw some light over this.
You take up by a psychiatrist. Psychosis is LBD. LBD usually has a lot of hallucinations. It's got a sleep behavior disorder. The REM sleep behavior disorder is a prominent feature. And they'll have some clinical, if you examine them, they might have Parkinsonism, gait impairment. So all these things actually, but all these things can there be late onset psychosis also, especially once it's got on treatment with antipsychotic drugs. They can have an imbalance. They also can have sleep disturbance. They also can have Parkinsonian features. So sometimes it's a very careful history taking to see what really started off first. When he had the treatment started with antipsychotic drugs actually started. So all these things might be important when you actually try to differentiate between these two. Again, a drug holiday can throw light into what if it is a something due to antipsychotic treatment. You can probably stop the drugs and observe the patient for some time and see whether he can revert back to normal. And that can give you a clue as to what is really happening. So these are my thoughts on it. I think probably a psychiatrist can throw more light to it.
Very, very nicely put, Dr. Raghunath. You covered the points. When you are trying to differentiate or get into this kind of a differential diagnosis, first and the foremost is history taking. An extremely meticulously taken history, covering all small points of what came first and what worsened the symptoms, gives a clue about what's happening. One of the factors that is commonly seen is the use of antipsychotics with anticholinergic drugs. And that's what creates problems. If we have to have an antipsychotic given to a person with some amount of cognitive deficit, one thing that I learned from a very senior physician who I work with in Mumbai at the Breach Candy Hospital is to give drugs with minimum sedation. In fact, 30 years ago, I realized that whenever this very senior, almost a god of medicine, anytime he referred a patient to me, and the next morning when he went on round, he wanted the patient to be awake. So I had to plan my treatment strategies in such a way that the patient would be awake when Bada Saab comes for his round. That taught me the use of liquid. It used to be Serenus haloperidol liquid in the past, and now we have risperidone liquid. So don't even give a tablet, give them liquid. And then my pharmacologist friends taught me all about first pass effect. So when you're giving drops, put them on the tongue, you're taking care of first pass effect. You get good pharmacokinetics and pharmacodynamics at use of minimal dose if we use in the form of orally absorbed drugs. Don't ever forget to rule out electrolyte imbalance and iatrogenic factors in these patients.
Thank you, sir. Thank you for your inputs in the question. There is a question from Dr. Paresh Shah, who is asking any treatment for MCI, any approved treatment for MCI, and any particular evidence or studies for that.
Dr. Raghunath, your call.
Yeah. I think most of the treatments for MCI have actually not shown much benefit. Probably the most important ones are like Wahia sir had said, exercise. So exercise, physical activity, exercise is probably the most important one. Most of the other drugs like donepezil, galantamine, rivastigmine, all of them have been tried, but does not have a sustained effect or does not have, they have very modest effects. So nothing has really shown that it can stop the conversion from MCI to dementia. Probably that's why we require this biomarkers so that we can catch these patients much earlier and probably put them onto newer trials. I think newer trials are all on the monoclonal antibodies. So all of these things are now coming up, trying to bring down the amyloid load in the brain. So most of these things have still not worked. So we still don't have a thing which works except for the non-pharmacological ones. Please, sir. Wahia, sir, you.
So this is a very interesting question. Do the drugs work? So I asked the patient or the relatives, work for whom? Work for the patient's relatives, or the drug company? The patient's relatives want the doctor to prescribe a medicine because it takes away their guilt. And pill for every ill is the culture. Patient also feels good that the doctor gave a drug. So never say no. To tell the patient that we don't have a medicine that will work for you is not a good answer. So what I ask is, what as the patient, what do you want? Do you want to try your own efforts and be the master of your mind and your body, or do you want to depend on a medicine? The depressed patients invariably ask for medicine. They would say, doctor, I'm trying, but I'm not able to find results. So give me something. In which case you might consider giving them an antidepressant and SSRI in a small dose. Dr. Lujad had a phenomenal study on 5 milligram fluoxetine to patients above the age of 65 complaining of cognitive deficit that does not show up on any tests, including MRI. So 5 milligram MCI, 5 milligram of fluoxetine for patients of who we lovingly call the MCI worked well. Dr. Lujad had used the RDC criteria, which we don't use anymore. But there is this one study. Most Indian fluoxetines are capsules of 10 milligrams, and we can't cut them into half. But of late, there is one company which has come up with 10 milligrams scored tablets of fluoxetine, which can be given in 5 milligram dose for patients of MCI. It may not improve their cognitive functions, but will improve their perception of their own cognitive functions at that smaller dose. There's only one brand of fluoxetine tablet, and that also is not easily available. Everything else is more like a placebo.
Thank you, sir. There is a question from Dr. Paresh that any role of SSRI in MCI or dementia without depression?
Dr. Raghunath, again, your
I think that's what I was saying. None of these drugs have actually worked. I think all of them have been tried. Even SSRIs have been tried, but nothing conclusively changes the conversion of MCI to dementia. So probably we have to have new drugs to, except for the, again, like I said, the non-pharmacological ones.
Dr. Paresh Bhai, nobody likes to be ill. The fact that a person is ill and has to go to a doctor in itself is an anxiety-provoking situation. Nobody likes a doctor. Even our spouses don't like us. Nobody likes a doctor. So for Dr. Paresh Bhai to say that a patient of MCI without depression, I think is purely a hypothetical patient. And I would advise 5 milligrams fluoxetine based on not my observation, but Professor late Dr. Lujad and his study on RDC when he was NIH director. SSRI, other SSRIs have not been used. There is no study. Fluoxetine 5 milligram is the only study that I know of. But some studies might have missed my cognition. And if you have a data, use it, but don't use it on a conjecture. But to say that a person is MCI without being anxious or depression is an oxymoron.
Thank you, sir, for the inputs. Dr. B. Ramesh Babu has asked that what is the evidence-based data that polylinguistic skills prevent forgetfulness?
I've read it. I don't know if there is any proven data. Dr. Raghunath might know, or probably Dr. Tiwari would know.
Sir, I also don't know about this data because I don't even have came across any kind of studies.
I think I'm actually not. I don't know a study, but I think learning a new language is shown to have some benefit in actually preventing the decline in cognition. And people who are bilinguals or polylinguals will have more area of their brain, language area actually being involved because they know more than one language. So this can be they'll have more area of their brain involved in this language usage when they use the languages differently. So probably they have more area. So degeneration has to be more before they have the same set of cognitive impairment. So that could be one reason. So plasticity is also been shown in older age groups. So probably if you learn a new language, that can actually improve your cognition, or maybe stay the decline in your cognition. But I'm not sure of any studies. I've not done a recent search on this.
COVID era, during the lockdown, endless number of patients would feel anxious, depressed, and would ask me about how to spend their time. And I used to tell them to try and learn something new. So it could be a new cooking skill, painting, drawing, music, or languages. And then my patients taught me that there are a whole lot of internet sites where you learn new language, Indian as well as international languages, without spending money. And a lot of patients that I know, though I have not kept the numbers, but a lot of patients I know learned new language during the COVID era, and they are happy that it was a spare time well spent, and it helped them to feel more alert during the COVID era. But I don't have science on this. This is purely a personal perception. Ravi sir?
There is also interesting question from Dr. B. Ramesh Babu. He's asking that in case of vascular dementia with subcortical involvement, statins may aggravate the depressive symptoms, and on the other side, sclerosis may cause further involvement in subcortical area. So it may increase depression. So what should we do? How to balance this in the clinical practice? Should we give statins, particularly in vascular dementia, or not? If the patient develops depression, there will be complaints of forgetfulness.
You ask me? Oh, yeah, okay.
Go ahead. Dr.
Go ahead,
Raghunath.
sir.
No,
Go ahead, sir.
I
No
thought
problem.
it was Ravi
Okay,
to
mine is a very brief answer. If you ask me, you have to definitely give the statins. And if you have a coexisting depression, and maybe you treat the depression with a different drug, because statins are very important, because if the patient's got a small vessel disease, which is a mark for subcortical damage, it's very likely that he's going to get it again. And statins are also useful for cardiac disease, and most of it's good for all vascular risk factors. So it might be risky to take off the statin, and then probably if you're not sure that depression is actually, the statin is causative for depression. So I think I would continue with the statin and probably treat depression separately. I mean, you are the experts, so probably.
Trouble here is that statins themselves are not very nice drugs all the time. They have their own set of problems, which are more prevalent, including some neurological symptoms that come up because of statin. And then it becomes pretty difficult. So we should be wary of the iatrogenic factors. I can see Dr. Tiwari sahab smiling, so I'm sure he has something to add.
I just wanted to highlight one issue, that the basic principle of starting a treatment is a diagnosable, say, illness, if it is depression or it is whatever. But where there is no treatment available for conditions like mild cognitive impairment, there you will have to use some alternative strategies, non-pharmacological management, counseling, or other such kind of treatments. You can't leave your patients. They expect something out of you. And most of our patients, they expect some kind of medication. And even at times, placebo medications also make them comfortable. So let us tailor-made a treatment situation, pharmacological or non-pharmacological, depending upon patient's diagnosis. And if it is the patient is suffering with this depression, diagnosable depression, then certainly you need to institute treatment for depression. Thank you.
Thank you, sir. There is a question from Chandra Prakash Small. He's asking the role of citicoline in in MCI. So, Raghunath sir, any comments on this?
Yeah, no, yeah, again, citicoline is probably not used in many of the countries. It's probably used. I think it's used in Russia, some of the Eastern European countries, and probably the Middle East, and probably in India. So we have not had very high quality studies on citicoline with MCI. MCI, the citicoline has been tried with stroke, and probably it has been found that it has been of any use. So I'm not sure of any studies which has been done with MCI, and the treatment effect is probably very modest and not enough at all.
Thank you, sir.
So I wouldn't use citicoline for MCI.
Okay, sir. I just want to ask another question from Sanjay Kumar Rathi. He's asking about is zolpidem a good drug to treat sleep deprivation? This is really interesting question because benzodiazepines are known to cause memory complaints, and CNS depression is another issue. So, Vahya sir, if you want to comment on this.
So zolpidem is an interesting drug. Where it works well, but where it doesn't, it causes paradoxical agitation.
Yes, sir.
So I would give the drug and watch the patient with hawkish eyes for any paradoxical agitation caused by zolpidem. I have seen, or not seen, but I have read report of zolpidem-induced automatisms where people start sleepwalking and endanger their life. So it's a good drug. And when we are not too sure, but where that seems to be the safest thing to do, start low and go slow and build it up to the patient's need and caution the patient against the risk of all these agitations and paradoxical sleepwalking and things like that, parasomnias. I've read about it. I have not seen a single case so far.
Thank you, sir. There is also another question from Dr. B. Ramesh Babu. He is asking about in this model medical practice, can EEG stand on par with MRI scan of brain in early identification of forgetfulness or in differential diagnosis of dementia? Particularly, he is asking for those who are not affording patients. So, role of EEG in differentiation of forgetfulness or diagnosis of dementia.
No,
Sir?
no role for the conventional EEGs at present.
No
There
role.
have been a lot of studies on the high density EEGs. So probably that has not come into the clinical practice, but for the conventional EEG, absolutely no role.
See, doctor, when we are dealing with dementias, we are dealing with a degenerative brain disorder. It's a structural disorder of the brain. The EEG does not show the structure of the brain. It only shows the electrophysiology of the brain. So it's like saying, can I do an ECG instead of doing an echocardiography? Well, you can't. They are two different, you're measuring two different things. So let's not compare apples and oranges.
You put it nicely, sir.
Thank you.
There is a question from Dr. Bhavesh Lakdawala who is asking that what would be future more effective possibilities for treatment for dementia apart from which are available currently. So he is asking there are any chance or scope of new techniques or new medicines for treatment of dementia in recent future.
I think lots of things are being tried, especially the amyloid reducing, that is monoclonal antibodies to reduce the amyloid. So these things work on the MRI, but the cognitive effect is not good. So probably that's why they're trying to treat earlier than this. They've tried a lot of drugs like growth hormone releasing hormone, then tesamorelin. So many drugs have been tried. Many vitamins have been tried, but I think none of them, as at present, has been found to be useful.
Dr. Bhavesh Bhai, artificial intelligence and technology is invading mental health care in a big way. And we honestly don't know where it's going to lead us. What we thought was impossible 5 years ago has become a routine line of treatment today with artificial intelligence in many branches of medicine, including neurology and to some extent psychiatry. So, yes, there is scope for hope, but before artificial intelligence takes over, I would be gone. So I don't have to be fighting with artificial intelligence.
So, sir, there is a question from Dr. Dev Kumar Mitra. There is a more kind of a psychological question that forgetfulness is common in stress-induced people nowadays lifestyle. So, please suggest a suitable lifestyle and rejuvenating self-counseling program. So, sir, this is a question from Dr. Dev Kumar Mitra.
Dr. Dev Kumar, one is a question of personalities. One of the commonest jokes that my students play on me is they would catch up with me wherever they meet up with me, and we would have long talk, and they would say, "Sir, just one question, sir, tell me my name," because I don't remember names. I would know everything about the student. I would discuss with the student some interesting events that would have occurred when the student was in my department. And my students would get together, pin me down and said, "Sir, just one question. Tell me my name." And that's where they floor me. So there are a lot of individual variations. And lifestyle also vary from person to person. What's good for one is not good for another. So the broad idea is keep your body and your mind active. The metaphor I say is that if you are physically active, is going to keep your mind active. Your physical activity is the foundation of the structure, and mental activity and psychological sophistication is the superstructure. So keep your fundamentals right. Proper diet habits, proper sleep is very important, which many of us miss, and avoid doing things for the pleasure if it is not healthy. Now, that's a broad, sweeping statement, and you got to pick and choose what you think is essential and healthy versus done for the fun of it. And then, if you do things for the fun of it, you weaken your foundation, you pay a price. But there is no 1, 2, 3, 4 off the shelf answer of what is healthy versus non healthy lifestyle. Jokingly, I tell my patients, "What should we avoid, doctor?" Well, I would say avoid bhang, ganja, and charas. Otherwise, you can do what you like.
Okay.
So one or two another questions. There is another question from Dr. Paresha who's asking about the role of melatonin, whether it is good for insomnia without jet lag, as far as the memory is concerned. Should we try it or not?
Paresh Bhai has got a whole set of questions.
Yes, sir. He's very active.
In the last about 6 months, there is a huge volume of data on the use of melatonin in regulating sleep cycle. The popularity of melatonin in sleep disturbances seems to have increased during the lockdown period, where the day-night margins and work from home led to blurring of the comfort zones and day-night margins. And the recommended dose, which was around 6 milligrams in the past, has now gone up to 20 milligrams. And it has helped. It doesn't help everyone. It's not a miracle drug, but it helps. And in most cases, it doesn't harm. But again, start low and go slow. Dr. Inla, what would you say? Or Tiwari Sahab would have some, Raghunath Sahab will have something to say.
I think so. I think melatonin is a drug which probably doesn't have that much of cognitive problems. So again, you have to start very low, and you have to time it so that the sleep induction is done nicely.
It's interesting.
So usually
there was a gentleman with renal disease, and he has gone through bariatric surgery. He's got obstructive sleep apnea, etc., etc. He would do well with melatonin. But when I started with 3 milligrams and went to 6 milligrams and went up to 9 milligrams at 8 p.m., he would sleep during the day and not at night. So now we have made it melatonin at 4 o'clock in the afternoon. And for 5 days that he stayed in the hospital, after we made 9 milligrams of melatonin at 4 o'clock in the afternoon, he says it has given him a new life. But that's just one anecdotal case.
Sir, I think in cases where they require more dose of zolpidem, just addition of melatonin and a combination of zolpidem with melatonin, I think the dose of zolpidem can be much less if you give a combination of these two. So that's what I have found in some of my patients. So you can just give maybe 5 milligrams of zolpidem instead of 10 or 15 and add some melatonin, maybe 5 milligrams or something like that. I think that works better.
So we are taking one last questions, and chairpersons are given the responsibility to identify the base question so that we can give amazing Amazon e-voucher of 4,000 rupees. The last question is from Professor Dr. Prasant Kumar Das, who's asking that in all cases of forgetfulness, should we administer antidepressants and besides some neurological medications? Your opinion in the issues. So can we
Individualized
give
treatment.
randomly?
No random treatment. That is medically not correct, ethically terrible. And I wouldn't sleep if I give a medicine without making a diagnosis. And this question has to be individualized. There is no sweeping treatment that can be recommended for a case like what we're discussing just now. But Dr. Raghunath's word is final.
Okay, thank you, sir. No, I agree with you completely there, because I think it's unethical to actually do that. And you find that most of these, in all these studies, they've said the vast majority of them are worried well. That is, they have just got the worry, they don't have a memory problem actually. So it's not right to treat them with antidepressant drugs.
So I think we are done with all the questions, and we are about to conclude the session. So I'm handing over mic to chairpersons and Banai for final words and giving the announcing the name of for the questions for today's webinar. Thank you.
Thank you, Dr. Ravi, and thanks the organizers and also the speakers, both Dr. Raghunath and Dr. Wahia, for the excellent. Today we had a very good evening with a lot of knowledge sharing, both on psychological and neurological aspects of this forgetfulness. And we had a number of questions. I think nearly about 14, 15 questions we had, and very interesting questions are also posed in this. So I think. What shall we about this selecting the best question, Ravi? Is there any common this thing where we can discuss and put it there, not openly
Yes,
discussing
sir.
here?
Yes, sir. We can the group which was
Now,
created.
mute yourself and call up Dr.
WhatsApp
Tiwari.
group.
Just mute yourself and call up Dr. Tiwari. And Dr. Tiwari sahab, you mute yourself and answer Dr. Inla. So we still have you on our screen and still not hear what you're saying. And if you can't decide which participant deserves the award, you can share it between the speakers.
I didn't look at entire say talk and questions and everything. From that point of view, that I will have to select a winner for the questions or for the talks. But certainly, the scientific content of Professor Raghunath and that of yours also were so well that it's very difficult to decide amongst the presentators that who is the best. The questions asked by Dr. Parekh, who quite active, were all very interesting. And if the participants are to be given that award, I think Dr. Parekh deserves it.
Congratulations, Dr. Parekh. Are we done? Do we log out? Or somebody is going to thank us all?
Sir, can you just confirm the name? Is it Dr. Paresh Shah or Dr. Parekh?
I feel that he is Dr. Paresh Shah. He has asked so many questions and led us to a great discussion in the session. So
I think Ravi, you are right. Dr. Paresh Shah. I'm sorry, I took the name of Dr. Parekh, but Dr. Parekh should also be given some consolation prize.
Raghunath Saab, they let us out of these all.
Yeah. I think so. Okay.
Okay, that's a great prize.
Thank you each and everyone for joining us today. We hope to see you all again on coming Tuesday. Please block your date for 23rd of February 2021. Same time from 8 p.m. to 9:30 p.m. Topic for our next webinar is complex psychopharmacology in medically ill patients. Also, based on many requests that we have received, we would like to inform you all that our previous webinar archives are now available on our YouTube channel, Banai India. Do let us send us your feedback and comments, if any, on info@banai.org.in. Till then, stay safe, stay healthy. Good night.
Good night, all guys. Bye.
Good night, sir. Good night, everyone.
Bye.
Thank you.